好，各位同事，歡迎大家嚟到我哋 Tsao Sin Talk。咁咧今日2023年10月16號，咁咧就今日非常之開心啊，因為咧就有一個我覺得係好叻嘅 speaker 上嚟，咁咧就講呢堂書。不過未介紹佢之前咧，我都想講一講有啲 message 我想講一講嚇。咁咧就其實流感季節就到啦，咁咧報紙咧就亦都睇到啦，流感咧似乎就慢慢喺度升緊，咁咧就我希望我哋大家做兒科咧，無論醫生護士，都希望咧大家鼓勵啲屋企人咧，即係啲父母啊，佢哋自己打針啦，帶個小朋友去打流感啦咁樣。咁我哋自己都要打針嚇，因為咧我哋如果惹咗俾啲小朋友咧都論盡。咁咧就我希望大家都盡快打針。嗱，我咧就打咗啦，我10月10號打嘅。咁咧就希望大家響應下呢個呼籲，咁咧就打呢個流感針。咁咧就今日咧好開心咧，就揾到阿 Sabrina 咁咧嚟講書。咁咧 Sabrina 咧，我係覺得好叻嘅一個 clinician 嚟嘅。咁咧就揾到佢嚟。我點樣識佢嘅咧？其實咧就係有一次咧，就佢喺我做喺兒童醫院 Sim Centre 嗰時咧，佢係打電話俾我，佢就話我可唔可以諗個方法咧，教下啲醫學生，因為嗰時我記得係 Covid 啊，咁咧佢就話好少機會啲醫學生即係上去病房度，咁咧就點樣學examine 個 cardiovascular system。咁我話我冇嗰啲咩 murmur 嗰啲，佢話唔使嘅，其實咧即係我哋都用好多方法都可以教到啲醫學生。咁我就覺得即係哇，佢其實好 passionate about 即係 teaching。咁我好 impress 嗰陣時。咁跟住咧就我睇下佢即係佢嘅 background 啦。原來佢係 clinical associate professor， 即係 Hong Kong U 啦。咁佢喺London Guy's 同埋 St Thomas 嗰度undergrad 啦。咁啊跟住就去咗美國啦。咁喺 Pittsburgh 啦做嘅 residence 同埋呢個 fellow。咁跟住應該就我諗係用咗好多時間喺 Chicago。嗱，有兩樣嘢咧，我覺得真係好犀利。第一樣咧就係adult with congenital heart disease。咁大家如果聽過喺度講咧，我就成日好 concern about 呢個即係 transition care。咁如果啲小朋友有 congenital heart， 咁佢過渡到大人點算咧？因為大人好少睇呢啲噶嘛。咁我諗哇好嘢喎。咁啊 Sabrina 就正就 fill 咗呢個 gap。咁第三樣，我覺得佢真係好叻嘅，就係做呢個嘢做physiology。呢個係我最驚嗰樣嘢。但係咧就即係呢個係幫到好多小朋友。咁咧佢又所以呢三樣嘢咧好難做嘅，即係教學生又好難做。adult with congenital heart disease 又好難。要做 physiology 更加之難。咁所以咧就今日好開心啊，揾到佢嚟呢度講書。咁咧就今日佢揀咗個 topic 咧，我諗係即係大家都覺得好難 manage 嘅嚇。啲小朋友佢 Syncope 咁究竟係咩事咧？係咪個 heart 有嘢定係其他有嘢咧？咁咧我就將個時間咧或者交俾阿 Sabrina 講個 topic。
多謝你，thank you Dr. Bill Chan。咁我都打咗流感針啦。咁就so my topic is going to be about syncope in childhood。咁我覺得我大部分都係用英文講嘅，咁但係我希望第日我慢慢講。如果人哋有需要嘅，我有啲名詞會係有中文啦，但係大部分嘅 talk 會係英文嘅。咁我冇 disclosure 啦。咁我今日嗰個talk 咧 I would like to define what syncope is and discuss some of the causes of syncope and actually telling you what are the important causes that we need to think about. And then what are the benign features of vasovagal syncope, which is by far the most common cause of syncope. And I'm hoping to use some cases to illustrate some clinical approach. So why do we worry about syncope? Well, the reason is that most parents, when their child faints, This is what they worry about. They worry that they will be the next tomorrow's headline. So in Hong Kong's secondary school student dies during physical education class in Tsuen Wan. In Singapore, a 16-year-old student collapses and dies after jogging during a PE class. And in India, class 10 student dies during sports meet. So I think this is all very common across the world. So what does syncope actually mean? So syncope, the definition is a transient loss of consciousness and the inability to maintain postural tone. But they should have a rapid and spontaneous recovery in the absence of features suggestive of other etiology, like seizures, trauma, stroke. So this is a very old painting. Then you can see a woman fainted, and everyone goes and look after her, put her down, lie her down to let her wake up. And this is a cartoon that is very, very typical. In a hot summer day, a child running around, feel dizzy, and then fell down. And so I think the question is, how common is syncope? It is actually very, very common. It accounts for about 126 per 100,000 children seeking medical attention. And if you talk about emergency room visit, it's a 1 in 2,000 ER visit is due to syncope. And believe it or not, about 15% of children will experience at least one episode of syncope before the age of 18 years. And what are the demographics? It is slightly more common in girls, and the peak incidence is between 15 to 19 years. So when I think of the classification of syncope in childhood, these are the big topic: cardiovascular, autonomic syncope or vasovagal syncope, neurologic, non-cardiac, and unexplained. And for obvious reason, I'm going to be concentrating mainly on cardiovascular syncope. But before that, I do want to talk a little bit about vasovagal syncope because it's so common. So this is how, in a layman term, I explain to patient and their family. Vasovagal syncope is the body's way to overreact to certain triggers. So like pain, the sight of blood, when they change position, or emotional distress. It causes a sudden drop in blood pressure and heart rate, and that's the reason why people passes out. These are usually harmless, and the importance is obtain a detailed history surrounding the episode, and particularly their fluid and dietary intake. And of course, you may need to rule out other causes. And I found this cartoon online in verywellhealth.com, and I think this is a perfect cartoon. So in the middle is someone who's clearly feeling dizzy, but it gives you all the warning signs of vasovagal syncope. So like nausea, suddenly feeling warm and sweaty, feeling faint or lightheaded. And if they have a witness, they usually appear really pale to the witness. And sometimes they will have blur vision, seeing bright spot or tunnel vision, and they'll have ringing in their ears. So these are all very typical of a vasovagal syncope. And people usually say, well, okay, we make the diagnosis. How do we treat that? So if you refer to the 2017 AHA guideline and the 2018 European guideline for vasovagal syncope, they actually talk about non-pharmacological therapy and pharmacological therapy. And the class 1 indication in the non-pharmacological therapy is actually patient education. You need to explain to them what they have, what the diagnosis is, and what the prognosis is. A lot of time is providing reassurance and trying to minimize the risk and avoid the triggers or situation that can cause syncope in that patient. In addition, it's a class 2A indication that you can treat them physical counter pressure maneuvers. So for example, if they are sitting down, you can have them pull on their hands, or if they are standing up, they can't sit down, they can move their leg just to move the blood around. And actually for the orthostatic training is a 2B indication. Now, for the salt intake and fluid intake, it may be a 2B indication, but this is a very easy to do thing. So I usually tell the family for their body kilogram in body weight, they should be drinking an ounce per kilogram of fluid, non-caffeinated fluid a day. And they should divide it equally throughout the day. And they should look at the urine color. It should be light yellow or colorless. Those are easy things for them to do. And because really pharmacological therapy is not the be-all and end-all. So what about pharmacological therapy? As you can see in both the AHA and the ESC guideline, all the pharmacological therapy are either 2A or 2B indication. And Florinef or fludrocortisone is the most commonly used and is actually a class 2B indication in both guidelines. Midodrine is more commonly used in the U.S., but is still a class 2B indication in the ESC guideline. Same thing for beta blocker, people use a lot in the U.S., but it is class 3 indication for in the ESC guideline. So that's all I'm going to talk about vasovagal syncope. So let's start with a case. So this is a 14-year-old girl. She's a competitive swimmer. She just completed her swimming practice. She complained of feeling unwell. She got out of the water, and then she passed out. She was not breathing, and she had no pulse. And so her coach started CPR. When the EMS arrived, they attached the AED to the patient. And you should know that for all AED, you can always get the tracing afterwards. So this is when we downloaded the tracing. What you can see is that when the AED was applied, the patient was in VF and shock was advised. And so a 200 joule shock was delivered. And then afterwards, they were doing CPR. At the time of the rhythm recheck, she was in sinus rhythm. So no shock was advised. So on exam, her height and weight are normal, saturation normal. Her cardiac exam, apart from pain around the AED pads, she has a normal cardiac exam. Neurologically, she was amnestic about the event. Otherwise, she has no neurological deficit. Her urine tox screen was negative, and her echo was normal. So her past medical history is really unremarkable. She has no history of medication or recreational drug use. In the family history, her paternal grandfather died in a car accident in his 50s. Her paternal aunt had seizures and died in her 20s, and a negative autopsy. The father and 2 other siblings are all alive and well. So whenever I look at a case, I try to think about what are the concerning features and what are the more benign features. So the concerning features is that she had syncope post-exertion, she required CPR, she has documented ventricular fibrillation, and she had a family history of sudden cardiac death and seizures. What are the more benign features in this story? There really is none. So for her, the differential diagnoses to me include channelopathy, coronary abnormalities, hypertrophic cardiomyopathy, and drug-induced. Now, we know that her urine tox screen is negative and her basic echo is normal. So at least these are less likely. And I think with her family history, we do need to think about channelopathy. And so namely long QT syndrome, catecholaminergic polymorphic VT, so CPVT, Brugada syndrome, and ARVC. So this is her baseline ECG. So what you can appreciate is that this is a normal sinus rhythm with sinus arrhythmia. She has a very tall, broad T wave that looks like a ski slope. And because of the sinus arrhythmia, the corrected QT interval measures out to be between 460 to 480 millisecond. So at least right now, her clinical diagnosis is that she might have congenital long QT syndrome. And you can say, well, it's easy for you because you're an electrophysiologist, you can look at all these things. Are there ways that perhaps we can figure this out without referring to someone right away? So I will talk about that in a minute. So for her, we started her on Nadolol, and we gave her a transvenous ICD for secondary prevention. We counsel her how to avoid triggers and certain medication. We did send genetic testing. It eventually came back to be KCNQ1 mutation, which is long QT type 1. And we performed family screening. I think the most important part is a shared decision-making with the family and the patient, because as you remember, she's a competitive swimmer. And so what we decided to do is we put her on the Nadolol, gave her an exercise stress test. She's beta blocked. She has no exercise-induced arrhythmia, and she's very compliant with her medication. And we did allow her to go back to swimming. So this is the Schwartz diagnostic score. So Peter Schwartz is this Italian electrophysiologist, and he has done a lot of research in long QT syndrome. And in his score, you use ECG finding, clinical history, and family history. So remember, there are nothing about genetic testing here. So if we look at our patient, she has a QT interval of 460 to 470 millisecond. She had VF, so that gave her 4 points already. She has syncope with stress, that's another 2 points. She had unexplained sudden cardiac death, less than 30 in her paternal aunt. Now, she had seizure, but still is a sudden death, less than 30. So if you put all of this together, she has at least 6 to 6.5 points. And if you are more than or equal to 3.5 points, there's a high chance that you have long QT syndrome. And so for long QT syndrome, it's important to do a history and the pedigree history. You may need to do several ECG because QT interval can vary. And exercise stress test is very helpful. And if you are concerned that they have it, then you should do genetic testing. And as I mentioned, the diagnostic score. And you can see that in LQT 1 to 3, which are the most common one, they're very specific T-wave morphology. LQT1 has a very broad-based tall T-wave. LQT2 has a notched T-wave. And LQT3 has this long isoelectric ST segment and a late peaking T-wave. There are definitely established risk markers for long QT syndrome. And importantly, for treatment, we want them to avoid QT prolonging drugs. And there is this website that is really nice to look up all of these medications. And you advise them on safe exercise. From a pharmacological standpoint, it's beta blocker, mexiletine, and then perhaps we need to give them atrial pacing, left cardiac sympathetic denervation, and ICD. Long QT is a fairly common arrhythmia syndrome, 1 in 2,000 prevalence, and the diagnosis is if the corrected QT is greater than 470 or 480 millisecond with abnormal T waves. However, 30% of gene carriers will have a normal QTC, and 30 to 50% of these patients are asymptomatic, and those are the ones that we are hoping to catch to prevent sudden cardiac death. The family history may have syncope, sudden death, seizures, congenital deafness, drowning, single car accident, and consanguinity. And there is a significant risk of sudden death of 4 to 11%. So let's go to our second case. It's a 13-year-old girl, again with syncope. When you asked her, she had one episode at the end of 2022. It was non-exertional, no prodromal symptoms. She recovered within a few minutes. It occurred at home, so they didn't seek help. This second episode happened while she was walking to class, and she collapsed suddenly. Excuse me. She had no twitching movement. She spontaneously recovered. And because of that, she was taken to the A&E. Her family history showed that her mother had frequent dizziness and sudden death at 30 years of age. This occurred while she was in China, and because of the family, no autopsy was obtained. She has a 12-year-old younger sister who is otherwise healthy. Her workup by the A&E showed normal hemoglobin, electrolytes, glucose, CK, troponin. Urine tox screen is negative. EEG was normal. Echo ECG were normal. So she was sent for an outpatient stress test. So while she was waiting for her stress test, we just started chatting. And it goes to show that history is really important. So I just asked her, by the way, what exactly happened? And she said, well, I was running late to class, and my classroom was on the 6th floor, so I ran up 6th flight of stairs to the classroom, and when I got there, I passed out. And she didn't remember anything else, but she remembered waking up on the floor. And when I asked about further history, so it turns out she was diagnosed with a secundum ASD when she was in China, and she had periodic echo follow-up, and she was eventually told that the ASD has closed. So due to her congenital heart disease, her parents have not let her participate in any PE classes. And when she was living in China, when she was young and was sick, they would go and consult a traditional Chinese practitioner. And what she told me is that they will幫佢把脈. And every time幫佢把脈, they will tell her that she has an arrhythmia. But whenever her parents take her to a local hospital, they will be told that her ECG is normal. So this is her baseline ECG. It was completely normal, normal sinus rhythm, normal PR interval, no ventricular pre-excitation, normal QT interval. And so when I think back about her case, the concerning feature is that it actually is post-exertional. And she has this really weird, horrible family history. What are the benign features? She did not require CPR, she was alert, and she has a normal baseline ECG. So for her, again, the differential diagnoses are the same thing as our last case. And again, because her tox screen was negative, her echo was normal, I ruled these two out. In her first ECG, at least it's not typical for the long QT 1, 2, or 3. So it could be CPVT, Brugada, or ARVC. And so we put her on the treadmill. And this is what happened when her heart rate went above 150. And I think you can see that across all the leads, there are these bidirectional ventricular couplers. And in fact, you can see that she has a run of non-sustained polymorphic ventricular tachycardia. So this is catecholaminergic polymorphic ventricular tachycardia, or CPVT. So we started her on Nadolol, and after she was on Nadolol, the repeat stress test was completely negative. We counseled her about exercise and medical compliance, and I actually told her father that even with this diagnosis, with the treatment, she should be allowed to participate in PE class for her cardiovascular health. We did send the genetic testing, and it came back to be positive for ryanodine 2 mutation. And we are planning for cascade screening for the family. For CPVT, again, it's the history, baseline ECG, exercise ECG. You do need echo to rule out structural heart disease. Genetic testing, unfortunately, is not always helpful. It's only positive in about 70% of the time, and so we are very lucky. The diagnostic test is this bidirectional VT. And again, there are some risk stratification criteria, and for management, it's mainly lifestyle counseling, beta blocker therapy, and sometimes they may need left-sided or even bilateral sympathetic denervation. ICD is really reserved for the very unusual case because they can get ICD storm, so it's not the first-line therapy. So if we look at channelopathies, there are tons. Even for long QT, there are at least 13 different types. So I'm just naming some of the more common ones that we see now, and the rest, you should just know about. So let's look at the third case. It's a 14-year-old boy with sudden onset of palpitations while carrying groceries. He felt dizzy and dropped his groceries, but he quickly recovered. But he still complained of substernal chest pain, diaphoresis, and nausea. So he called 999 and was brought to the local emergency room. In the emergency room, he was described to have an irregular heart rate of 180 beats per minute. His blood pressure was 80/50. He was alert but very diaphoretic. He had no prior history of palpitations. This is the presenting ECG, and I think you will all agree that you can see these irregular QRS complexes, and they are very wide. So this is an irregular Y complex tachycardia, and I can understand that this can be very scary. But because he was still very alert, people thought maybe we can try a dose of adenosine, and they did. And this is what it looks like. So it became even more scary with very rapid monomorphic YQRS tachycardia of 300 beats a minute. Then there is a slower, narrow QRS rhythm without any obvious P wave, and then went back to a slower but still YQRS irregular tachycardia. Due to the hypotension, he was given sedation and cardioverted. His labs came back to be normal. His urine tox screen was positive for cannabis. Echo showed a structurally normal heart, normal coronaries, no valve abnormalities. So what are the concerning features here? He had an irregular Y complex tachycardia, and he had hypotension. He required cardioversion. What are the more benign features? He's alert, and he actually didn't require CPR. So for him, the differential diagnosis, again, polymorphic VT. Is it really CPVT? He was carrying groceries, maybe. And perhaps because of the irregular rhythm, he had atrial fibrillation with aberrancy, or something called pre-excited atrial fibrillation. So let's take a look at his post-cardioversion ECG. You can see that he is in sinus rhythm because it's upright P wave in 1, 2, and AVF. But you can see a very short PR interval and a very obvious delta wave in lead 1, 3, V2, V5, V6. So the short PR and the delta wave means that he has ventricular pre-excitation. So what he has is that he has underlying undiagnosed ventricular pre-excitation. And probably from the cannabis that he smoked, he had drug-induced atrial fibrillation. And he had symptomatic pre-excited atrial fibrillation. And because of that, subsequently, he underwent an EP study and catheter ablation. So when we talk about ventricular pre-excitation, what are the concerns? 20 to 30% of them will develop SVT, supraventricular tachycardia, with the peak in infancy, adolescence, and second decade of life. This is not the life-threatening part, but they have a lifetime incidence of atrial fibrillation of 8 to 18%, and that's higher than in the general population. And the risk of sudden death is less than 0.015 per patient year. And this is because if they have developed atrial fibrillation and they can have rapid conduction in the WPW, they can develop ventricular fibrillation. And the incidence of VT is 0.32 to 1.4%. So in older patients with pre-excited atrial fibrillation with rapid ventricular conduction, like our patient, we will offer ablation. In younger patients, we will treat them medically until they are old enough to have the ablation. My last case is a 16-year-old boy with syncope after playing basketball. He recovered quickly, but because of it, he was seen by a pediatrician. He told the pediatrician that he has not had breakfast that morning and he has not had much to drink that day. On examination, he's non-dysmorphic, but he does have a soft systolic murmur. His past medical history is negative, and he's a very active boy. He plays basketball, soccer, tennis, and never had any problem. He swears he's on no medication and had never ever done any recreational drug. He is of Indian descent. His parents are second cousins. A maternal uncle died in his 20s during a pickup soccer game, and they didn't do an autopsy because that was back in India. This is his ECG, and what you can see, if I can show you the left-sided leads, 1 AVL, V4, V5, V6, you can appreciate these very, very, very tall R waves. In addition, you have these very abnormal T waves, so and a left axis deviation if you look at 1 and AVL. So what this is that this is quite severe left ventricular hypertrophy with huge voltages, left axis deviation, and a repolarization abnormality. So the concerning features, again, this is post-exertional syncope. He does have a soft murmur. There is consanguinity in the family and left ventricular hypertrophy on the ECG, as well as the family history of sudden cardiac death. The more benign feature is that he did not require resuscitation, and he truly had poor oral intake prior to the syncope. So for him, the differential diagnoses should include vasovagal syncope. But because of the murmur and all of the other stuff, we need to think about hypertrophic cardiomyopathy, aortic stenosis, athlete's heart, malformation syndromes, and mitochondrial diseases. Because he doesn't look dysmorphic and no obvious myopathic problem, I can at least rule out the last two. His labs are again normal, but his echo does show hypertrophic cardiomyopathy with a very thick interventricular septum, but he didn't have much of an LV outflow tract gradient, and he has normal LV function and no RV outflow obstruction. So we gave him lifestyle counseling, and for him, it's really important that he has adequate fluid intake. He can do exercise, but he should avoid varsity level activities. We did perform exercise stress tests to make sure he has no exercise-induced arrhythmia or syncope. And we will continue surveillance of progression of his left ventricular hypertrophy, outflow tract obstruction, and development of ventricular arrhythmia, and we will give them genetic testing. And he was positive for the MYH7 mutation. And so hypertrophic cardiomyopathy is common. It's 1 in 200 to 500, and is defined as increased LV wall thickness without any abnormal loading condition, such as hypertension. 40 to 50% of hypertrophic cardiomyopathy will have a genetic cause. Most of them are autosomal dominant, and MYBPC3 and MYH7 account for about 70 to 80% of them. And there is a risk model calculator, and you can actually use this online calculator for children to see how high risk for sudden death they are. And if they have outflow obstruction, you may want to treat them with beta blocker, verapamil, diltiazem, or disopyramide. And sometimes we will give them primary prevention ICD or subcutaneous ICD. If they have severe left ventricular outflow obstruction, they may require surgical myectomy or percutaneous septal ablation. and you need to continue lifelong surveillance with echo, cardiac MRI, Holter stress test to look for any worsening of outflow obstruction and development of arrhythmia. And of course, we need to screen the first-degree relatives. So what are the structural heart disease that can cause syncope that we really care about? So I just talked about one of them, left ventricular outflow obstruction, so hypertrophic cardiomyopathy or aortic stenosis, coronary artery abnormalities, pulmonary hypertension, and dilated cardiomyopathy. And we don't have time to go through every single one of these. So when we look at the history and symptoms for channelopathy, these are the things that I look for. In long QT, syncope with swimming, exercise, emotion, seizure in sleep or upon awakening, history of aborted sudden cardiac death, maybe family history of consanguinity. For CPVT, is really exercise or emotional induced syncope, and that can include temper tantrum. So a toddler may present after they have a temper tantrum and they drop to the floor. And they may have family history. Brugada syndrome in young children, it may be a fever-induced syncope. In older people, it may be exercise-induced syncope. And again, they may have family history. In structural heart disease, what are the concerning symptoms? I think the recurrent theme is the exertional syncope. And for coronary artery stenosis, abnormalities, it can be exertional angina. And that's true for aortic stenosis as well. And for these patients, they may have a cardiac murmur, which is unlike channelopathy patient. Their exam will be completely normal. They may have family history, they may have palpitation. And one word about dilated cardiomyopathy is that it's less common that they have exertional syncope, but rather they may have exercise intolerance and palpitation because they tend to present with signs of heart failure. But of course, syncope can be part of that. So when I look at the red flags in history, so in vasovagal syncope, there are really no red flags per se. So I think you really want to try and elicit the situational type syncope. They have prodromal symptoms. It's a quick and complete recovery. Look for the fluid and dietary history. The family is usually negative. And as I said, for channelopathies and structural heart disease, the exertional syncope really get me. And if they fall down mid-stride, that really get my attention. If they have syncope with injury, that get my attention. If they have exertional angina, that definitely get my attention. Drowning, seizure upon awakening. So a lot of the neurologists now, actually, if they think they have Rolandic epilepsy, they will refer to us to at least get an ECG to rule out long QT. If they have a murmur, you should definitely think about structural heart disease. And then, as I said, ask really specific family history. And so when does syncope warrant urgent cardiac evaluation? Exertional syncope, exertional angina plus or minus syncope, syncope sustaining injury. And I haven't mentioned this group. If it's one of our congenital heart disease patients, if they come to your ER and have a syncopal episode, they should be presumed to have a cardiac arrhythmia and potentially life-threatening etiology until proven otherwise. And if they don't have a follow-up with us soon, they should be referred back to us quickly. And we don't mind you calling us and letting us know about that. So finally, syncope may be very benign, but I know that it can be a harbinger of potentially life-threatening events. So you need to do a thorough history and examination and a detailed family history. Vasovagal syncope can coexist. Differential diagnosis will guide your subsequent tests. Basic investigation will include 12 lead ECGs and maybe a basic echo. Further testing for arrhythmia syndrome may include Holter monitor, exercise stress test, event monitor, although those are now almost obsolete because everyone seems to have Apple Watch or LifeCore. Further testing for structural heart disease may be a more detailed echo, cardiac MRI, CT coronary angio, and maybe even a cardiac cath. Genetic testing should be done with caution. We need to provide really good pre- and post-test counseling. And they need to understand that if they have a positive test, that may impact them and they may not be able to get any life insurance. So with that, I want to thank you. These are my pediatric EP team at Children's. Thank you.
好，咁咧好多謝Sabrina 今日呢堂書。其實大家聽完之後發覺原來咧，我哋做漏好多嘢，平時我哋修正即係原來啲 history 好重要嚇。我哋以往咧就即係好多時一入嚟即係做個 ECG 啊，再唔係就 Holter 啊咁樣。原來頭先聽你講咧個 history 同埋即係頭先我特別留意你講兩樣嘢，有啲咩 concerning features、more benign features。我諗呢兩個咧就係我諗我哋啲 junior 或者啲醫學生咧，呢個我哋都好想教佢哋，即係唔好就係睇咗個 symptom 就跳落去做乜咁樣。咁但係你頭先有一張 slide 都係講啦，話有時都要做 Holter 咁樣。又有時咧，我哋又靠啲即係啲 consumer product 啲標啊咁樣。佢哋有幾有用咧？即係譬如 Holter 咁嘅有幾有用咧？
Well, so for Holter, I think for 我平時用咧就係有幾樣嘢嘅，即係如果佢話日日都有 symptoms 嘅，咁當然你可以試下啦。咁但係好多時你就係俾佢戴 Holter 嘅時候咧，佢就係冇 symptom 嗰日㗎。係咯。咁都冇辦法啦。咁for ventricular pre-excitation 嘅 patient 咧，其實我哋睇緊嘅咧，佢就會唔會即係耐唔中係 intermittent 嘅？譬如一日裏邊佢嘅心率高啲嘅時候，就冇咗 pre-excitation 啊，又或者佢有冇一啲 arrhythmia， 其實佢自己都唔 aware of 嘅。咁我覺得嗰樣嘢係有用啦。咁至於你話 Apple Watch 同埋 LifeCore， 其實而家其實仲有好多有啲係 Android 嘅錶都可以錄嘅。So I am talking more about the ECG recording than the heart rate recording. So 其實有我哋好幾個嘅 teenager 嘅SVT patient 我哋真係 document 唔到嘅，咁佢翻嚟第二次翻嚟真係俾個 Apple Watch 嘅 recording 俾我 ，and nowadays 嗰啲 recording 係真係好好嘅，即係大部分人係錄到嘅。咁個 LifeCore 咧就最新嗰款咧就直情係有6個 lead 嘅 ECG 嘅，咁所以亦都真係可以俾到好多資料俾我，同埋而家嘅 LifeCore 比較平啲啦，即係冇 Apple Watch 咁貴啦，咁所以都係 OK 嘅。咁而且我而家嘗試緊喺兒童醫院都可以買啲係可以，譬如租俾病人啊，譬如1個月俾佢啊，等佢用下，即係嚟到嘗試 catch 呢啲 symptoms 咯。
另外一樣成日好多人想問，譬如話有一個 survive 咗呢啲咁嘅 Syncope， 又係真係 arrhythmia，我哋跟住點 advise 佢嘅 risk 咧？即係有啲就真係好驚嘅，即係譬如佢真係要個 CPR， 頭先你第一個 case 咁佢真係又要 CPR 啊咁佢點樣 counsel 佢呢個 lifestyle？ 你頭先有講到啦，但係實際上即係啲人有幾驚咧？我哋係點樣幫佢解決呢個問題
？Depends 嘅，我覺得即係好似我第一個 case 係好 unusual 啦，個 long QT 嗰個，因為佢係真係一個好叻嘅 swimmer 嚟嘅，咁佢係即係 that was her life。咁佢如果唔游得水咧，佢就 I think that will have a huge psychological impact on her。咁我哋亦都 explain to her that for long QT type 1。Swimming is a triggering event, but she's very good with her medication. Her parents understand that even with the ICD, there is a risk that she can drown, and her coaches know that. But also because she's a competitive swimmer, wherever she goes is always in a pool where there's AED, there's lifeguard. 所以佢 in a way 就好好彩咯。咁 so for that it is easy. Now some people are not like her, and they are very active and they want to continue, but the parents are very worried. So now there is a conflict between the parents and the child. And so 嗰陣時咧，我哋做醫生嘅咧，即係我覺得好容易。我話你唔好做運動啦。但係我諗for 尤其是一個 teenager 咧，you have to have the buy-in。咁所以有好多時我哋真係會見佢好多嘅，真係 make sure。你哋有冇食藥㗎？你係咪準時食㗎？如果你哋係想做運動，你要多少少 responsibility， 你唔可以淨係叫爹哋媽咪提你食藥嘅喎。咁我哋同你做個 exercise stress test。同埋做 Holter， 點解我哋做呢啲嘢咧？其實係睇下佢個 heart rate 係咪 suppress 到，因為我哋可以睇到佢究竟係咪食緊藥嘅。咁嗱，當然啦，佢可以嗰一日食緊藥嘅，咁但係即係 at least 你都可以睇到係有冇 protection 咯。咁另外有啲譬如話裝咗機嘅，有啲對個小朋友嘅psyche 係好大嘅影響嘅，因為佢睇到個 scar 啦，同埋裝咗機嘅唔好處咧，就喺細蚊仔嚟講咧，有20% 嘅細蚊仔咧係可以有 inappropriate shock 嘅。And I think that is the one that as physician we struggle with。咁所以我哋真係要 balance 你個 risk 幾高，係咪真係需要呢個 ICD， 我哋先至俾佢咯。咁有啲人譬如好似 Hypertrophic cardiomyopathy 嘅，你可能個 first event 係 sudden death 嘅。咁我哋個 Hypertrophic cardiomyopathy 係有個 risk calculator。如果我哋真係計到你個 risk 都幾高嘅 ，then we counsel the family。有啲人係話我唔要嘅。我就算話aborted sudden death 我都唔會要噶啦，咁我哋都唔會逼佢要啦。但係每次翻嚟我哋都會再 counsel 佢嘅，係咯。
仲有一個問題，好多人都會問嘅，即係佢話咁 Syncope 咁你頭先當然有好多 elaborate 嘅 workup 啦，咁但係未 workup 到之前咧。你點樣 advise 佢？譬如話 exercise 啊，即係細路仔佢學校實問噶嘛。明白。咁我哋會點樣做咧？即係譬如一個 general physician。
So 我覺得好多 pediatrician 就係 face with 呢個。咁所以我始終覺得咧，大部分真係我諗70至80% 係 vasovagal syncope 嘅。咁所以我真係覺得，如果你話你個 history 係好 consistent 嘅，咁同埋我有陣時就會問，咁你有冇發覺，尤其是係嗰啲 teenager 咧？ If you ask them, they really don't want to drink at school， 因為佢唔想去廁所，佢覺得嗰啲洗手間好核突嘅，佢真係唔想去洗手間。佢每日如果你問佢，我去1次咯咁樣，即係佢係大部分時間。但係如果你問佢哋飲水，我飲好多水㗎，咁你幾時飲啊？返屋企飲咯。咁我點解你喺學校唔飲啊？我又唔想去廁所。So you can definitely get that kind of history。And 你如果問佢，有啲人係真係好容易 vasovagal 嘅。咁如果你坐咗好耐，忽然之間起身，你會唔會有少少即係暈暈地㗎？咁佢話啊有㗎。同埋佢如果 vasovagal 嘅，真係好多時佢哋係有好 typical 嘅 prodromal symptoms。咁最常見咧就係佢好似睇到眼前嗰啲雪白花咁樣。如果佢都唔暈咧，佢就真係覺得係 tunnel vision 嘅。咁如果佢都唔暈咧，佢有陣時覺得係耳嗡嗡聲嘅。咁有啲想作口作悶，所以我係真係問得好仔細。佢就算唔話俾你聽咧，我都真係想知。如果真係 vasovagal， 而你個 baseline ECG 1個2個係真係正常嘅，我係會話你要飲水，你要食翻嘢。如果你係咁咧，你可以去翻做運動。但係如果你做緊運動嘅時候有呢啲 prodromal symptoms 咧，You have to stop and sit down and rest。咁我會係寫一張紙俾學校咯。咁我 rather than 係 restrict 佢，我會話如果個細路係 complain of 呢啲 prodromal symptoms 咧，你要俾佢停。咁但係我諗，如果嗰啲話真係完全冇 symptoms 暈低咧，咁我就真係要睇一睇先啦。咁我覺得嗰啲咧，你話喂，你都我見咗個 cardiologist 先咩啦？咁我覺得嗰個係 reasonable 嘅。但係我覺得如果你係好 typical 嘅咧，我係會話俾佢聽，你唔使 restrict 佢嘅，係啊。
哇，好實際啊！你而家講嗰啲advice 咧，我諗即係我哋啲 junior 同事或者我哋自己或者啲 medical student 咧，即係要學到呢啲嘢嚇，即係原來我哋好多嘢可以幫到我哋點樣幫啲小朋友。咁咧就今日呢一堂書咧，其實就有啲 adult cardiologist 都聽緊，我知道。咁咧，我想問嗱，我哋你又會 manage 啲patient with congenital heart that going into adulthood。咁呢啲小朋友你點樣過渡佢去大人咧？即係你 diagnose 到即係 some form of pathology causing syncope， 咁你會點樣過渡佢去大人
？So depends。如果係ventricular pre-excitation 嗰啲 ，I hope that we will get rid of it before they turn adult。咁就至於你話 hypertrophic cardiomyopathy 啊，同埋真係coronary artery abnormalities 啊 ，dilated cardiomyopathy， 其實我哋而家咧，我要 thanks to 周柏昌醫生啦，同埋陳希信醫生喺兒童醫院，佢哋係 run 一個 transition program 嘅。咁所以如果我哋 diagnose 咗之後咧，到佢哋10零歲開始咧，我哋會係refer 去個 transition program。咁我哋會坐低同佢傾下，究竟個細蚊仔知唔知道呢個 diagnosis 係點咧？佢哋係明唔明佢有啲咩嘅 lifelong 嘅monitoring 啊 restriction 啊？咁然之後我哋就 as they become adult， 我哋如果係好 complex 嘅，我哋會 refer 翻去我哋自己 ACHD 個 clinic 喺 QM 嗰度睇嘅。再唔係咧，如果係比較普通啲嘅咧，我哋就會 refer 去各位大人嘅 cardiologist 去 follow 咯。咁我哋都會好彩兒童醫院都俾我哋喺 outpatient 一路睇住佢哋 until they get transition to the adults。
非常好啊！即係我好 concern 呢樣嘢嚇。係啊。呢排我成日都講，即係呢無論咩 condition 咧，其實你哋大家都要諗下個 discharge plan。discharge from pediatric， 但係咧 admission into adult service。咁咧網上有個題目咧就係 Any role of TIL test on the investigation of syncope in childhood？
So to me is a no。講真，因為 Vasovagal 咧係is a clinical diagnosis，and 其實有啲tilt table 嘅咧係就算普通人你冇 Vasovagal 咧都可以 positive 嘅。咁所以我覺得嗰個 sensitivity 同埋個 specificity 真係唔係好高咯。唯一一樣嘢咧係真係好少，除非你係覺得佢係 psychogenic 嘅，咁你係唔信佢嘅，咁你可以 tilt 佢哋。咁有啲佢真係，哎呀我真係暈咗啦。咁你見到咧，其實 BP 啊 heart rate 係完全正常嘅。咁我記得我 Chicago 個 mentor Barbara Deal 咧就會點咧？佢會企喺嗰個細蚊仔隔離啦。咁如果佢真係咁咧，咁佢就會拎高佢隻手 ，and then 咧就咁樣。即係跌咗佢，睇下喺佢頭度跌咗佢。如果佢係 psychogenic 咧，佢一定唔會即係打自己，咁佢會喐開嘅。咁但係如果你真係 Vasovagal，佢真係會拍親啦。咁所以 I think that's the only way。所以我哋而家都做少咗好多噶啦，係啊。
好精彩啊！咁咧就呢個問題咧係阿 George 醫生啊，George 大家好熟悉。咁我哋喺度再次多謝澳門嘅同事咧，佢哋好捧場佢哋啊。咁咧就成日都好準時收睇我哋呢個。咁咧今日我諗即係我哋學到好多嘢嚇。其實我係好怕呢個題目嘅，但係你講完之後咧，我發覺原來有方法去學嘅喎嚇。第一件事即係有一個好 detail 嘅 history 嚇，咁就跟住有啲即係要慢慢分析 ECG 啦，同埋有啲而家最緊要就係有啲 genetic test 即係幫到我哋。咁我哋 test 其實幾耐先會翻到個報告
？Depends on 佢哋個 standard answer 就幾個月嘅，咁但係有啲如果真係好緊急，即係如果真係嗰啲 abortion sudden death 啊，或者真係有好多 diagnostic dilemma 嘅，佢哋有陣時可以 within 幾個禮拜幫到我哋嘅。但係因為始終佢哋嗰個workload 係好緊要咯。
其實都幾重要，即係揾到個原因咧都幾緊要。有時喺個即係如果係一個 family
我諗即係譬如好似 CPVT 同埋 Long QT 嗰幾個咧，其實 we already got the clinical diagnosis before the genetic testing。咁所以我覺得你個 reason for genetic testing 咧係如果你係 positive，you can then screen the rest of the family。Before then we will get them to get ECG and things like that，but 始終都係好難，尤其是如果你係 abortion death，多數啲 parents 會話well what about 佢個阿哥或者佢個阿妹？Do we need to worry about them？ 即係嗰啲係反而個 genetic testing 係幫到咯，因為如果佢係冇嘅，咁 you don't need to worry about them。因為如果係 autosomal dominant，都係 1 in 2 chance 嚇。
好，咁咧就大家都同意咧，呢一堂咧係非常之有用嚇。咁咧就我都喺度咁多位，而家我大家見到阿 Sabrina 個 team， 其實咁多位我都係好尊敬佢哋嚇，因為其實congenital heart disease 或者 children with heart disease 咧，其實係once 你 make 到個 diagnosis， 你有 specific treatment 咧，你救翻佢啦 ，bring a lot of changes to their outlook 咁樣樣。咁咧就睇下先，我仲有啲乜嘢想講啦嗱，咁咧就喺度都要呼籲下，就大家咧如果未 join 我哋嘅 YouTube channel 咧，麻煩大家 subscribe。可以 scan 個 QR code 啦，中間最大嗰個，或者去下邊嗰個網站嗰度。因為咧就我哋大概希望一個星期都，就算冇live 嘅咧，我哋都有一啲片擺上去。咁啊，以前我哋拍落嗰啲，我哋 edit 咗啊，咁樣樣。好啦，咁咧就呢張相咧就我頭先 share with Sabrina， 咁咧就其實係差唔多10年之前影嘅嚇，嗰陣時我喺Ireland 嘅 College of Physician 嗰度，咁呢個伯伯係邊個？佢已經即係離開咗我哋，咁咧佢係 Dr. Ward 嚇。而家我哋個個講 prolonged QT syndrome 咧，就好少講呢個 Romano Ward syndrome。咁咧呢個就係 Dr. Ward， 好 nice 嘅。咁我喺Ireland 見到佢，咁佢好誠意拳拳走埋嚟，即係同我傾偈啊咁樣。咁所以原來即係我哋而家識咁多嘢咧，都係好多人喺近時咧做咗好多 research 啊咁樣，做咗好多 publication 咧，先幫到我哋救翻啲小朋友。咁喺呢度咧向阿 Dr. Ward 致敬啊咁樣樣。咁咧就我哋今日嘅時間咧就差唔多啦。喺走之前咧，就我想送一個紀念品俾阿 Sabrina， 就喺台面度嘅，喺台面度，我唔過嚟啊，因為呢度好多電線。咁咧就係以義為先嚇，以義為先。咁我諗Sabrina 唔係淨係以義為先，佢以心為先。唔係淨係我哋即係 anatomic 個心，佢係即係個 passion 嚇，個 passion towards 即係病人啊咁樣，同埋 medical student。我估你係一個非常非常之好嘅老師嚟，即係 the way 頭先你咁 systematic 咁 present， 又令到我哋咁容易了解呢個咁 complex 嘅問題啊咁樣樣。咁好多謝你嚟緊咧，我希望約你一次，之後咧就講一講啲 congenital heart disease。What if they grow into adults？ 究竟佢哋點樣適應啊咁樣？咁呢個係即係好重要嘅。作為兒科醫生，我諗我哋都要知佢嘅 natural cause。我哋可以點樣幫佢？咁咧今日就好感激阿 Sabrina 嚇，好多謝你嚇。
Thank you。
咁咧就替我問候你爸爸嚇。
Okay，thank you，thank you。
佢好似仲喺度睇緊啦佢。